Good evening, everybody. After a long gap, 1 month again, we have just started our webinar this month. It is on intra-articular injection using anatomic surface landmarks. At the outset, I must welcome all the participants who have joined in this webinar on behalf of SVNIRTAR, Department of PMR. I welcome you all. So today's talk is on intra-articular injection using anatomic surface landmark. This intra-articular injection, we are almost everybody we are doing. It may be a bit new for the juniors, but it is quite common and experienced by the experienced physiatrist. Almost every day in every OPD, some cases of requiring intra-articular injections we get and we inject as OPD procedure. However, there are some deep-seated joints which require OT setup and fluoroscopy guidance or ultrasound guidance for intra-articular injections. Today, we'll discuss on intra-articular injections using anatomical surface landmarks. So this intra-articular injection can be considered as an adjunct to the core treatment for short-term reduction of moderate to severe pain in various intra-articular pathologies. There are different injection techniques we use for injecting into the joint. It can be freehand injection using surface landmarks, which we are going to discuss today. Ultrasound guided injections, fluoroscopy guided injections, and CT guided injections. All techniques has its own advantages and disadvantages. For ultrasound guided injection, the physician must be well trained in ultrasound. He should have facility of ultrasound in his own laboratory, and it is not feasible as a out OPD, busy OPD procedure. So for that, freehand techniques is required. Fluoroscopy guided injections are mostly required for deep-seated joints like hip joints, sometimes shoulder joint for injection procedure. Again, that requires a special equipment, special OT setup. Every setup will not have that facility of CR or a dedicated OT. And at that time, we required to have competed in freehand injection using surface landmarks. And moreover, if those facilities are available, still we should trend in freehand techniques because that reduces your duration of procedure and that reduces your CRM exposure if you are trained in the surface landmark techniques. So today's talk in the technique of freehand injection using surface landmarks. Use of intra-articular injection. When we use intra-articular injections, it's mostly therapeutic procedure, but sometimes we use it as a diagnostic way of treatment. Sometimes in deep-seated joints, like a patient complains of pain around the groin, it's very difficult to diagnose it, whether it is arising from piriformis, whether arising from SI joint, arising from the hip joint. So that causes a diagnostic confusion. Sometimes we need to go for intra-articular injection to hip joint to rule out that yes, the pathology is either in the joint, inside the joint, intra-articular, or it is extra-articular. That time it is very much helpful as a diagnostic procedure, injecting some local anesthetic into the joint. Similarly, shoulder also, when you have a confusion that whether this pain is arising from intra-articular origin or extra-articular origin, that time also sometimes helps in diagnostic. Therapeutic indication, we all know that is very much useful for by a minimal invasive procedure or in the most forms of a part of conservative management for dealing with numerous conditions. Those indications are like osteoarthritis, very commonly used. Osteoarthritis of knee, first line of treatment. Earlier days, we were people are thinking that the steroid will cause this, that, but still it is a first line of management for osteoarthritis knee. And other joints osteoarthritis also like hip joint and other areas of secondary osteoarthritis conditions starting in early ages where replacement is not possible. There also steroid is the choice of treatment in those situations, secondary osteoarthritis and rheumatoid arthritis in adjunct therapy to GMRD. The intra-articular injections are required to relieve inflammation of the joint, reduce pain from acute inflammatory arthritis conditions. Then gouty arthritis, sometimes very painful with gouty arthritis, pseudo gouts. In these conditions also intra-articular injections are very much helpful. Connective tissue diseases, shoulder periarthritis or adhesive capsulitis helps a lot by injecting into the joint so that you can reduce the pain, and that helps in mobilizing the joint, that helps in strengthening the rotator cuff group of muscles, that helps in early rehabilitation in shoulder periarthritis or adhesive capsulitis. Other conditions with peripheral joint manifestations such as ankylosing spondylitis, psoriatic arthritis, Ritter's disease, all these conditions with a peripheral manifestations. There also the injection into the peripheral joints has a great help along with the treatment of the disease itself. There are contraindications to the intra-articular injections also. There are certain absolute contraindications that includes overlying cellulitis or an infected joint or infected bursa over the joint where the injection into the joint is contraindicated. You are likely to inject the bacteria or infected material into the joint. So it is absolute contraindication. If you feel there is a cellulitis around the joint or over your point of entry, it should be contraindicated. Any severe overlying dermatitis which is infected also, that's a absolute contraindication to injection into the joint. Severe bacteremia, allergy to any other medications like any local anesthesia that is allergic to the patient can cause also this allergic reactions, is contraindication. Prosthetic joints, especially in case of pain around the knee joint after total knee replacement or total hip replacement, there also it is absolute indication of injecting into the joint because these are very delicate situations. If you inject into the joint, you are likely to face post replacement infection or septic arthritis. That's a devastating condition for the patient. There are certainly relative contraindications also where you can give injection with little bit causes like uncontrolled diabetes. Yes, you can give injection, but you have controlled the diabetes. Then you can go for injection. Significant obesity are relative contraindication. Very uncooperative patients, difficult to inject in PD setup. So the relative contraindications of coagulation disorders may likely to go for bleeding episodes into the joint. So these are also relative contraindications to intra-articular injections. What are the common used intra-articular injections? Drugs used are most common is corticosteroid. Everybody is using corticosteroid. Many of us are using corticosteroid. The reason behind is that it's very cheap. It is it has less side effect. It has immediate effect and in terminal stages of arthritis. So very often we use these drug corticosteroids for intra-articular injections for relieving inflammatory inflammations inside the joint. However, other drugs are other conditions like injection to PRP, platelet-rich plasma. Of course, this is a regenerative medicine. It is yes, it is very much helpful. But it is helpful in early or moderate stage of arthritis. Like corticosteroid is very much helpful in advanced stage of arthritis, where no other choices there except replacement, and patient cannot afford for replacement. Then maybe the corticosteroid is the only choice in that situation. However, PRP is also helpful, but it is helpful in early stages or moderate stage of arthritis because it's a part of regenerative medicine. And prolotherapy is not taking that interest among physiatrists, but PRP is certainly. But PRP disadvantage is that you need equipment, you need a setup for preparing PRP, and patient have to explain properly that it's not an injection which will give you immediate effect. So it will take long time, long-term effects are there. So these are some disadvantages. And ozone, some people use ozone for intra-articular injection, reducing pain, intra-articular pain. Botulinum toxin also evidences are coming nowadays for injecting botulinum toxin into the joint also. The mechanism is not well understood. This is a injection is supposed to affect in the neuromuscular junction. However, people have used it in the joint and have shown effect of relieving pain. The spasticity around the joint, which is one of the cause of pain arising from the joint, and that is relieved by botulinum toxin. I said the most common drugs used by all of us is the corticosteroid. There are a number of corticosteroid molecules are there. They are injecting those steroid into the joint. The common drugs used are hydrocortisone acetate, triamcinolone acetonide, triamcinolone diacetate, and triamcinolone hexacetonide, and methylprednisolone acetate. So these are the steroids used for intra-articular injection procedure. However, out of these, the triamcinolone acetonide and methylprednisolone acetate commonly comes as a deformator. These are the two depot steroids most commonly used by all of us. But however, other drugs can be used. Every steroid has its advantages and disadvantages. We'll have discussion with a few steroids comparison statements between steroids. So as the volume of steroid, amount of steroid depends upon the size of the joint. The more capacious joints like shoulder joint, hip joint, knee joint, they require more volume. And joints like ankle joint, elbow, wrist, these are small compact joints. They have less volume. So the injecting amount will be less for the small joints, and the larger joints requires a larger volume. Sometimes require 5 ml or 6 ml like things that there you have to reconstitute with addition of the local anesthetics. These are few papers which comparing different molecules of steroids. Like this is a paper published in currently in 2022 in BMC Rheumatology. They have compared triamcinolone hexacetonide with triamcinolone acetate. Triamcinolone acetate we are commonly using. This hexacetonide, no, it's not so commonly used. However, it has advantage over triamcinolone acetate. This triamcinolone hexacetonide is superior to triamcinolone acetate in duration of clinical remission in patients with juvenile inflammatory arthritis, and this the slower absorption and release of slow release that helps a prolonged effect, and it has a longer duration action up to 24 months has been recorded, and it has been shown to is especially reduce synovial T cell lymphocytes, which is associated increase in inflammatory cytokines. So this mechanism helps in reducing inflammation and in better way, in a prolonged way in comparison to triamcinolone acetate. And we also use methylprednisolone very commonly because this is a depot steroid. Probably if you take opinion of physiatrists, probably many of us prefer methylprednisolone over triamcinolone. So if there if these comparison things are there, the methylprednisolone is suggested for superficial soft tissue injections like tennis elbow, where you have to inject in a superficial tissue. But triamcinolone is better effective for deeper site of injections. Methylprednisolone provides more immediate and prolonged improvement in pain, stiffness, and improve joint function. It is published in 2015. It's a comparative study published in International Journal of Scientific Study. They compared these things. They found that the methyl both have its own advantages and disadvantages. Methylprednisolone is suggested for superficial tissue injection, and triamcinolone is for the deeper site injections. Okay, so the corticosteroids are also not free of complications. They have their complication, local complication as well as systemic complication also. What are the local complications? They causes tissue atrophy. They causes fat necrosis if you inject into fat, not to the deeper tissue, not loading the steroid over the bone itself. You have by mistake injecting into the fat, that causes fat necrosis like plantar fasciitis. They sometimes causes erythematous flushing of skin Skin depigmentation, if by mistake you are injecting subcutaneously, that causes a depigmentation, especially in superficial area, that creates ugly depigmentation site over the skin. Nerve damage, if by mistake injected over the nerve, can cause nerve damage. Tendon rupture, though we think is a larger way of tendon rupture, but the incidence is less than 1%. Post-injection flare-up symptoms is found in 2 to 5% cases. Some systemic complications of corticosteroids are Charcot-like arthropathy, like steroid arthropathy, posterior subcapsular cataracts, pancreatitis, of course, rare, Cushing syndrome, fluid retention, osteonecrosis. So all these things are only when the corticosteroid is absorbed in systemic circulation. How the steroid we are using are mostly depot steroid. That's why these systemic complications are very rare in intra-articular injections. So iatrogenic infection also possible if you are doing in not taking adequate aseptic precautions. So iatrogenic infection also possible. There is a condition called steroid effect. Yes, this is, we all know there is a possibility of a side effect of corticosteroid that's called steroid effect. That's a self-limited synovitis can occur in approximately 1% to 10% cases following intra-articular injection. The reason behind is that these are all steroid. They form granules inside the joint. These granules deposits on the synovium, and the granules sometimes they mimics the physical property of a monosodium urate crystal or a pyrophosphate crystal, like they produces gouty-like features or pseudo-gouty-like features. So they exactly behave like a monosodium monourate crystal because the property of the pigmentation of the property of the deposited material same like a monosodium urate crystal. Periarticular injection capsule periarticular joint capsule calcification sometimes occurs because of injection. Of course, that is a late complication. Many of us combine local anesthesia to corticosteroid. Almost everybody is using that. What is the reason behind it? That the local anesthesia act as a solvent for corticosteroid because you know that the corticosteroids are very dense, thick, so the volume is less. So you need a solvent for spreading of the steroid across the joint. So it acts like a solvent. It provides volume for inject where distribute in the joint, like capacious joint, like knee joint. If you inject 1 ml, it will be stay inside the suprapatellar pouch. So you need to spread the whole steroid into the whole joint. So for which you need a larger volume. And the local is the best solvent for increasing the volume of a drug. And it provides immediate analgesia. So because the steroid takes some time for its analgesia effect or anti-inflammatory effect. So this addition of local anesthesia provides immediate analgesia effect so that patient immediate relief of that often giving a diagnostic information related to the potential pain source. If the pain is arising from the joint itself, immediately after injection, the patient will get relief. That indicates, yes, this is a intra-articular problem and my injection is going to work. So this gives a diagnostic information to the physician. But there are still controversies there, use of local anesthesia, any complication to the joint. Yes, local anesthesia may be associated with chondrotoxicity. There are papers published on that. The chondrotoxicity effect of local anesthesia. This is published in 2010 in JBJs. There are another article published in American Journal of Sports Medicine. This is this article is on effect of local anesthesia on articular cartilage. They conclude that the intra-articular use of local anesthetic may have a lasting detrimental effect on human articular cartilage and the chondrocytes. Although the clinical relationship between local anesthetic and local anesthetic exposure and chondrolysis requires further study because this study is a experimental animal study. So they suspect that it has a deleterious effect on the articular cartilage. However, still further studies are required to confirm the bad effect of local anesthesia over human chondrocytes. So coming to different local anesthetic we use for intra-articular injection. Commonly used injections are lidocaine or bupivacaine. Lidocaine available 1% or 2%. Many of us use 2%. Bupivacaine also, this is a long-lasting local anesthesia. Many of us prefer 0.5%. It has a lasting effect. 8 hours, of course, the duration of onset is late of 30 minutes in comparison to lidocaine, which is quick acting. The effect starts within 1 to 2 minutes, but the duration sustained for 1 hour. So some people also go for cocktail, adding both the drugs together so that the lidocaine will give you immediate effect and bupivacaine will give you a effect and sustained effect. The anesthetics and the anesthetic and corticosteroids can be mixed in the same syringe and injected simultaneously. This technique relieves pain at the target site, allows the area to be re-examined, and helps determine if the drug has reached its destination or not. If the pain is reduced immediately, that indicates yes, the drug is perfectly deposited in the right place. I was talking of cocktail. Yes, the people are using this cocktail method. All papers are also published on that. Use of cocktail, that is combination of equal volume of triamcinolone, 1% lidocaine, and 0.5% bupivacaine. Normally 1 ml each, that constitutes 3 ml. That represents a mixed solution that can be used. That's a cocktail. The results are better. It's published in this literature. The reason behind it that lidocaine gives a immediate effect and bupivacaine gives a sustained effect, so that patient will have overall good results. So we use different size needles for different joints, whether it's a deep-seated joint or a superficial joint. Normally we use 22 or 25 to 25 gauge needle, that is 1.25 to 1.5 inches long. That is most appropriate. And a 16 to 8 gauge needle is required for aspirate when you suspect the infected joint. You want to arthrocentesis, you want to aspirate the pus, you need a larger bore needles like 16 or 18 gauge needles, which helps in aspirate the joint. And sometimes spinal needle size around 20-22 size are required for injecting the deeper joints for like hip joint or shoulder joint. Local desensitization required for a patient which is uncooperative. Also, you can use all the patients also, that will give a soothing effect during the first insertion needle through the skin. Many of us use vapocoolant spray. We use prior to injection to decrease entry pain. The spray for the 3 to 5 seconds and wait for the fluid to evaporate before injecting. Immediately after injection will not relieve of pain. So wait for a few minutes, the drug let it absorb over the skin, have a local anesthesia effect, then go for injection. If aspiration is not necessary, this procedure may not require. Accuracy of needle placement, whether in the right place or not, that can be confirmed by use of contrast and can be used by use of fluoroscopic method. You will confirm it. You can aspirate the joint. If the fluid is coming out of your syringe, that indicates that you are yes, you are inside the joint. Contact with the articular cartilage. Suppose you are injecting to the joint, trying to inject to the joint, but you are not able to negotiate into the joint, and you are hitting the cartilage. That means you are inside the joint. Try to negotiate the syringe between the articular surfaces. You will be inside the joint. Water vapor in the nozzle, that indicates you are in the joint. Air injection, you inject air, it will go smoothly. So these are the points by which you can confirm that yes, your needle placement is accurate and you are inside the joint. If you are placed the needle in the wrong place, that means if you are not inside the joint, what you will find? You will have pain with initial fluid bolus. When you start injecting, patient will complain of pain because you are injecting wrong side. You are not inside the joint. You are injecting the tissue. When the tissue will swollen, spread, that causes pain. Resistance to injection, you are finding deep resistance. Yes, some compact joints, they are, you find some resistance, but the resistance is more when you inject to the tissue instead of joint. So you'll have a resistance to the injection. Visible expansion of the soft tissue. If you are injecting to a subcutaneous joint like knee, and if you are not inside the joint, so you may get a swelling of the soft tissue. The visible expansion of the soft tissue, discomfort with leg extension or ambulation post-injection. So patient will have a discomfort when the patient start working or start using the joint. He will have discomfort because the drug is deposited outside, which is swelling or inflating a tissue which is not supposed to be. That causes some amount of discomfort to the patient. So these are the indications of that the needle is not in the right place. There are certain cardinal rules for intra-articular injection. Always aspirate. Always aspirate to confirm that your needle is inside the joint. Maybe some joints you may get a dry tap, but still you try to aspirate the joint. A slightest drop of joint aspiration of fluid indicates that yes, you are inside the joint. Never inject against resistance. If you are feeling resistant for injection, think twice putting the drug into the joint. Rather, you change your direction of needle, try to get the resistance-free movement of the syringe, then you will confirm that you are inside the joint. Always know your anatomy, where you are injecting, whether you are right point or not, your total of entry is right or not. So you must thorough about the anatomy, whether you may injure to a nerve, you may inject the drug into a vessel. So these are all the complications. So always know your anatomy before for injection. Never forget to discuss the side effect of the injection, compare the effect of the injection, the prolonged effect of the injection, and the limitations of the injection. All things must be discussed with the patient before going for injection. There are certain absolute rules for injection. Take strict aseptic precaution, use sterile equipments, and local antiseptic precaution. These are very important. In hurry mode, sometimes we inject into the joint in OPD setup without taking care of these parts. Believe me, many patient who are injected in OPD setup, subsequently they come with a subacute or chronic synovitis condition. The reason behind it that you have not properly prepared the site of injection. All synovial joints are very delicate joints. All synovial joints should behave like a ear, like an eye. So if you inject in an unstable condition, every possibility is there. But at the tip of the needle, at the eye of the needle, a bit of the skin tissue will pass into the joint, enter into the joint, along with the tip of the injected syringe, especially when you use a large bore needles like 18 gauge needle. Every possibility that it will carry a piece of skin into the joint, which is infected. So always we don't have any rights to harm a patient rather than helping a patient. So always this absolute rules is that always take adequate precautions, aseptic precautions before injecting into joint. So these are all equipments. I hope you all know what are the minimum equipments required for injecting into joint. Now we'll discuss about the different joints of the lower limb. Different portals of the joints. We'll discuss one by one joints. The knee joint, the very commonly common joints used for intra-articular injection in OPD setup. Every all the students must be using this injection into the joint. It's a more superficial joint, do not require any sort of high-end equipments like ultrasound or any CR. So one must know about the different portals of intra-articular injection. So common portals of intra-articular injections are anterolateral, anteromedial, and mid-patellar and suprapatellar also. There are other people are also saying that mid-patellar, lateral mid-patellar, medial mid-patellar, suprapatellar, anteromedial, anterolateral. Some people describe 5 portals of injection into the joint, and out of these 5 portals, the most common portals are the mid-patellar, anterolateral, anteromedial, anteroportals. All the portals have their own advantages and disadvantages, separate indications for each one, and depends upon expertise of the physician who is giving injection. On the portal on which the physician more converts, more words about the portal of entry. These are the injection. Let us have a look on that. There are the different effectivity, anterolateral and anteromedial. If you see that the accuracy rate is anterolateral is 71% and anteromedial is 75%, and the lateral mid-patellar injection has highest accuracy rate, that is 93%. The reason behind is that the lateral mid-patellar injection, there is no tissue, no muscle on the lateral except the lateral retinaculum. So once you are injecting into the joint, crossing the retinaculum, you are inside the joint. So there is no other tissue forcing the needle to be traversed to enter into the. That's why the lateral mid-patellar injection has highest accuracy rate. And if you look to the different landmarks of anatomy, this is shows a anterolateral portal. You can see that a fat pad will come before injecting to the joint. So the advantages or disadvantages I can say here is that the anterolateral and anteromedial, if you are well versed, go through that. But lateral mid-patellar is the most safest way of injection. But the problem in anterolateral, this is actually it's a portal of entry for all arthroscopic procedure. This is the lateral portal for arthroscopy, knee arthroscopy. So this is the safest way of entering into the joint. How the disadvantages are that if you are injecting through that, and if you are not sure inside the joint, you are likely to inject into the anterior fat pad. The second thing is that the anterior horn of the lateral meniscus on the and for the anteromedial portal, anterior horn of the medial meniscus, you may encounter injection. You have not entered to the right place. So for entering into the joint through anterolateral portal, you have to palpate the skin of the tibia, palpate the joint line, go proximally. If you feel joint line, there will be a sudden loss of resistance here or depression here. You will confirm that this is lateral joint line. From distal to palpate, distal to proximal. When you get a deep recess here, that means this is the lateral joint line. If you go just above the joint line, you are likely to injure the anterior horn of the meniscus, whether lateral or medial. So it's better to go for 1 centimeter above the lateral joint line. 1 centimeter above the lateral joint line. If you go here at this point, you will eliminate injury to the anterior horn of the lateral meniscus. Also, you will eliminate the fat pad. The fat pad is more deposited more distally than proximally. So this is a safe procedure. If you are well acquainted with this, the best one. And here the needle should be directed towards the intracondylar nerves. So the entry point will be 1 centimeter above the lateral joint line. In the series, the needle will be directing towards the posteriorly towards the intracondylar nerves. The same thing is applicable for the medial side also. However, the lateral side is more acceptable than the side. And this is another one is the lateral mid-patellar approach. Here is also this is one of the safe procedure for injecting into the knee joint, because in the lateral side you don't have any other. In contrast, medial side you will encounter a thick vastus medialis muscle, especially when you are giving injection to muscular person. The medial side is the vastus medialis muscle is more muscular in origin. For lateral side, it is the lateral retinaculum only, and the patella is well palpable. On the lateral margin of patella is well palpable, and lateral condyle of the femur also well palpable. So you palpate the lateral margin of the patella, palpate the lateral condyle of the femur, and go just this in between it. And if required, if by mistake you are injecting and hitting to the any of the articular surface, like you are hitting to the femoral condyle or hitting to the articular cartilage, the patella, you can readjust a needle and insert into the joint. So one of the confirmation is hitting to the articular cartilage. That also confirms that you are inside the. Some people also prefer to go for injection into the suprapatellar pouch here, straightway just above the upper pole of the patella. It is not adequate for injecting a small amount of even like 3 ml injection into the joint. So if you want to inject through the suprapatellar pouch, you have to have a larger volume of injection. So when to use the suprapatellar pouch approach, when you have a large effusion into the joint, you need to aspirate the joint. Yeah, you can aspirate the joint like hemarthrosis or tense effusion because of arthritis. There you can aspirate through the superlateral approach from the suprapatellar pouch. For all practical purpose, the anterolateral is the best one. It has highest accuracy. Next is the mid-patellar is the highest accuracy, and next is the anterolateral portal. These are ways by which you can take. You can see it here, 1 centimeter above the lateral joint line, so that you will not encounter the meniscus. Here is also in extended position in mid-patellar, lateral entry, lateral portal, and straight into the joint. Only retinaculum is here. There are certain indications where absolutely you have to go with a specific route of injection into the joint. For example, in a stiff knee with a quadricep contracture, post-traumatic knee, where is the intra-articular injury is there, patient develops secondary osteoarthritis in the knee and knee is stiff. You cannot bend the knee to 90 degrees. In this procedure, you have to ask the patient to sit on a couch or sit on a chair, hanging the leg down. It is not possible in case of post-traumatic stiff knee with painful knee. So there you have to go for mid-patellar lateral entry. So when to go for intralateral entry? When patient is having severe arthritis, patellofemoral arthritis. Severe patellofemoral arthritis, there are a lot of osteophytes on the lateral margin of the patella and lateral margin of the femoral condyle. Hardly you will get any space. Each time you inject into the mid-patellar region, you will hit to the osteophytes. It is very difficult to insinuate the needle into the joint through mid-patellar lateral approach. That is indication where you have to go through the anterolateral approach or anteromedial approach, because the osteophytes are very less common anterolateral and anteromedially. So these are the indications of different portal of entry of injection for knee and accuracy rate of different portals. Since the MRI find, you can see there are a lot of fat pad in the frontal area to go in anterior area to go for a intra-articular injection from the front. So if you have not gone deep enough, if you have not aspirated the joint, you have not collected the joint fluid, you are likely to deposit the steroid or anesthesia inside the fat part, which is present infrapatellar fat pad in the anterior part of the joint. So coming to next part is the hip joint. It is less commonly used joint for injection by surface lineman. Most of the times we require the help of ultrasound or require help of CR guide. But however, one must know about the surface marking of injection to the hip joint. The reason behind is that because anytime your CR may fail, anytime you may misdiagnose, you may find problem in getting the joint through ultrasound. It's a deep-seated joint. So one must thorough about the surface marking landmarks. By that, you can reduce the number of CRM shots. You can enter the needle through the anatomical landmark, then confirm by fluoroscopy method by 1 or 2 shots is maximum required. But if you go straight to without using landmark, you may require more number of shots, which is not good for health. So one must know about the landmarks. So there are different methods of injecting the hip joint. We'll discuss 3 methods here. Injecting of this the hip joint. This is a method where the vertical line is drawn. A line is drawn from anterosuperior spine to center of the patella. This is the line from extending from anterosuperior spine to center of the patella. Another line is drawn from the tip of the trochanter to the this vertical line from the anterosuperior spine. This must be perpendicular. So this is perpendicular line drawn from this vertical line to the tip of the trochanter. This is point B. Why the point A? Point A is the line connecting the anterosuperior spine base to the tip of the trochanter. This imaginary line, the entry point would be the upper 2/3 or medial 1/3 and lateral 2/3. This is the point of entry of the needle. Upper or medial 1/3 and lateral 2/3. This is the entry of your needle, and the target is the point B. So you will go enter through point A, that is upper 1/3 lower 2/3 junction, and direction of needle in coronal plane would be to the point B. So you place it with the needle till it touches to the neck of the femur. By hitting to the bone, you confirm that you are inside the joint. So that can be confirmed by fluoroscopy guide also. And the angle of needle insertion is around 30° posterior tilt to the surface. Second method is the radiographic assessment. You can take a radiograph, X-ray film, AP view of the hip joint to be injected, and the X-ray criteria must be that it must be 100% magnification of the joint. So you can take magnification by putting a roll or a ball to confirm that how much of magnification is that X-ray. So preferably here is a 100% magnification is required for measuring the accurate measurement. So here, by taking a 100% magnification AP view of the hip joint, the anterosuperior spine is marked. The cephalic junction of the femoral head is marked here, and the inferior, the caudal head and the neck junction is marked here. And these measurements are taken by drawing lines. The line is extending from anterosuperior iliac spine down, and the horizontal lines connecting from the cephalad head and neck junction 90° to the vertical line, and caudal head and neck junction horizontal line perpendicular to this vertical line. Then measurements are taken. What is the measurement of this distance? This distance. What is the measurement of the upper horizontal length? What is the measurement of the lower horizontal length? So after taking the length measurement, you can prepare your landmarks over the skin, taking out these measurements. So if you compare with the previous X-ray, the anterosuperior iliac spine is measured here, and the length measurement here, it is the 13.93 total length. So 13.93 length is measured from anterosuperior iliac spine to the drop line. Then the second point, this point is decided by this measurement of 2.9 centimeter from this 2.9 centimeter, and the lower horizontal line 4.7 centimeter is the 4.7 centimeter, and the injecting site will be in this area. So it is these two lines corresponds to the upper margin of the neck and lower margin of the neck, and the cephala neck and head junction. So this is the site of the injection. Here you can inject directly vertical to the joint without any angulation. Perfectly perpendicular injection to the skin surface. Needle is directed. The needle will hit to this neck and head junction over the neck area. Once you hit to the bone, that means you are inside the joint. This is a second method of anatomical surface marking from a X-ray taken with 100% magnification. The third method is also another method by taking measurement that you draw a perpendicular line from the medial margin of the anterosuperior iliac spine. And the rest of the measurements were from the tip of the anterosuperior iliac spine. Here it is the medial margin of the anterosuperior iliac spine. Draw a perpendicular line and draw a vertical line perpendicular to the this longitudinal line. It is extending to the trochanter. It is not to the tip of trochanter. It is middle of the vastus ridge. Middle of the vastus ridge. Vastus ridge. This is the vastus ridge, and this is the middle of the vastus ridge. And a line is drawn perpendicular to this drop line from the medial surface of the anterosuperior iliac spine. So this is the point of entry for the hip region, and here also the needle can be directed perpendicular vertically to the neck, 90° or perpendicular to the skin surface. Okay, so these are three methods where you can use for hip joint injection. However, if you have facility of C-arm, you can confirm by fluoroscopy method. If you have facility of ultrasound also, you can confirm by this. If you don't have those facilities, you can use any of the three methods for injection. Take care that you are far away from the femoral artery. You know, this arrangement is within artery nerve from lateral to medial. So lateral is the, sorry, medial to lateral. So nerve is the lateral most, is the medial most. So you palpate the femoral artery. It should not come on the way of your syringe or entry point. Certainly, if you take the landmarks, you will not encounter any femoral vessel through entry portal. Next, coming to the next joint is the ankle joint. Ankle joints injections are not so common because the arthritis conditions are very common in other larger joints. But however, ankle joints sometimes require like post-traumatic arthritis conditions, also part of rheumatoid, then part of other arthritic conditions also requires injection in the ankle joint. The diagnostic indications for ankle joint injections are where you need to confirm that yes, the pain is arising from the joint. That is for evaluation of non-articular arthritis, evaluation of suspected septic arthritis, evaluation of joint effusion, identification of intra-articular fractures, identification of crystal arthropathy. These are the diagnostic indications where you can inject dye into the joint or inject local anesthesia into the joint to confirm that yes, this pain is coming from the joint, not from the from extra-articular area. There are therapeutic indications of injection into the ankle joint that relieve of pain by aspiration of the effusion. If it's a traumatic condition with huge swelling of the ankle joint, you can aspirate the joint, immediately patient will have relief from pain. Injection of medications like corticosteroids, antibiotics, anesthetic into the joint, and when it is infected, septic arthritis, drainage of the joint sometimes required to decrease the bacterial load, to decrease the tension of the joint and so surface landmarking is very much helpful for ankle joint. It's a very compact joint. Space is not that much of adequate like shoulder, hip or knee. So this is a compact joint formed by the tibial plafond proximally, medial and laterally by the medial and malleolus. You can see it here, the space is not that much adequate. It will have overhang of the tibial plafond anteriorly. It's very difficult to insunate the needle straightway anteriorly. And there are vital structures also present anteriorly, which may encounter when you inject, when you enter your needle into the joint. So you are likely to injure the number of structures present anteriorly. If you just for your recapitulation, if you go through the vital structures, the anterior aspect, there are the most medial is the tibialis anterior muscle, and next is the extensor hallucis longus. Next is your the peroneal nerve, the peroneal nerve, then dorsalis pedis artery, then extensor digitorum longus, peroneus tarsius, and superficial peroneal nerves, two branches supplying the dorsal part of the foot. So these are the structures present in the anterior aspect of the ankle. So one has to be very cautious during introduced joint not to injure nerves or injecting drugs into the vessel. So how to decide the entry portal? We have two recesses only. If you see, this is called anterior medial recess or anterolateral recess. These are the 2 points where the joint is maximum voluminous. You can have a space. There are least overhanging of the joint in this area, and needle can be easily insulated without damaging to the vital structure. Most of the vital structures are the middle area. So for accessing the two recesses, well, injection can be done to the medial recess, injection can be done to the lateral recess. Both recesses are helpful for ankle joint. However, if you feel that the tenderness is more on the lateral recess, you may expect a small loose body into the lateral recess or any articular damage in the lateral recess, or pain tenderness over the medial recess also indicates there is some arthritis on the medial the ankle joint. So either injection can be given. It depends upon which entry you are burst that decides your entry point. So if you discuss, we will discuss one by one This is the medial recess injection. Injection the medial recess is the most easy way of injecting into the joint. The way that you palpate the medial malleus first. Palpate the medial malleus from tip of the medial malleus go proximally on the most medialmost margin, lateralmost margin of the joint, that is anterior margin of the medial malleus, and feel the tibial center. Ask the patient to do dorsiflexion, resisted dorsiflexion, mild resistant dorsiflexion. That will cause prominent of the extensor tendons. The tibialis anterior or extensor digital longus. All these muscles will be prominent. So if you go for with a mild resistance, you will find the lateral boundary of the your entry point, that is tibialis anterior, and already you have palpated the medial margin or the anterior margin of the medial malleus. Go proximally. If you feel a deep recess here, you can palpate the distal part of the platform of the tibia. This is the medial margin or anterior margin of the malleus. Laterally, it is the center. This is the entry point. There is no chance of injury to the any nerve here except saphenous nerve, bit medially, further medially. But if you are right in the soft spot, this is called soft spot of the ankle joint. So that if you are right point, you are unlikely to cause any injury to the joint. So this is about medial recess. So before going that, you try to outline the joint. One finger on the lateral recess, that is your index finger, medial finger on the medial recess, and you choose which way you want to go. The medial recess portal I have already explained. For the lateral portal, the same way you palpate the tip of the lateral malleus, go proximally along the anterior border of the lateral malleus. Ask the patient to go do dorsiflexion. You go for registered dorsiflexion, you will see that the extensor digital longus will be more prominent. So that is your medial boundary of lateral anteportal, and the lateral malleus anterior margin is the most of the anteportal. So in between these two, lateral malleus and extensor digital, that is the site of entry. If you look at here, so this is your extensor digital longus, and this is the lateral malleus. Here is the site of injection. But you can see it here, this area is traversed by the superficial perineum, supplying the cutaneous sensation on the dorsum of the foot. That's why this lateral entry is less preferred the medial entry. Medial recess, everybody for medial recess. There are another entry also between tibialis anterior and the extensor hallucis longus, that is used for the ankle arthroscopy procedure. That is also a safe procedure for giving injection. However, for all common practical purpose, the anterior medial recess is the most common, most safest entry portal for injecting into the ankle joint. The next joint is the subtalar joint. This is a deep-seated joint. Should be the pain from the subtalar joint should be differentiated from other pains around it, like sinus tarsi pain or sinus tarsi impingement. This posterior subtalar joint, we have three facet joints in the subtalar joint: anterior facet, middle facet, and the posterior facet. This posterior facet is often go for a primary osteoarthritic changes in the subtalar joint. So this is, you can see in this Excel, this is Excel is showing a posterior facet arthritis or the subtalar joint. This is a common joint go for primary osteoarthritis in the subtalar joint. So to relieve the pain, subtalar joint injecting into the posterior facet is required. This is done by a lateral approach. Keep the patient in a lateral position with lateral surface of the ankle joint and foot facing up. Place the fingers on the lateral surface of the talus and on the posterior fibula. The landmark here is the posterior fibular margin. Please remember it, because the other joints to subtalar joints are anteriorly placed. For injection to the posterior facet is posteriorly placed, and it is easy to palpate because it is lying just below the posterior margin of the lateral malleus. Okay, you try to feel the calcaneum, you try to feel the talus. If not possible, then posterior margin of the lateral malleus is being a guide for injecting into the joint. So here a 25 gauge needle is required with the angle of 30 to 45 degree cephalad direction and 45 degree median direction. This is for the subtalar joint. Don't worry, if you are not confident about the subtalar joint in the posterior facet, then you can also inject into the subtalar joint here through the sinus tarsi with a good volume, which can again also versus posteriorly help certain extent in relieving pain of the posterior facet. However, in case of isolated posterior facet arthritis, this procedure is important. If the pain is more from the sinus tarsi area, in case of calcaneal fracture, old calcaneal fracture, most of the times they are managed conservatively and they leads to a subtalar arthritis because the fracture line many times go to this angular junction here. The angular junction, this is the most common side. The fracture line traverses up to this. So when the fracture is managed conservatively and it's malunited, the patient comes to you with a pain at the subtalar joint or an ankle joint. Patient confuses with the ankle pain, but actually that pain is arising from the subtalar joint. The typical they complain the pain is walking is more aggravated when walking on the uneven surface, walking on slow, walking when the foot needs to be inverted or inverted. The subtalar joint is coming to play, and the pain will be marked in the subtalar area. And this injection has a both diagnostic and therapeutic value. Here, the soft spot is identified. It is anteriorly to the lateral process of the talus, and you can palpate the anterior margin of the lateral malleolus, go down around 1 centimeter below. You can palpate the soft spot. Everybody, if you go for inversion, you can find the soft spot on the lateral side over the sinus tarsi, and you can inject into the joint. If you are injecting, you can confirm it by fluoroscopy method. First injecting the dye. You'll see that the dye is covering whole middle facet and the posterior facet. Then you can go for different injection of the corticosteroid. Other injections are first metatarsophalangeal joint. This is required when we encounter cases like hallux rigidus, hallux valgus pain, secondary osteoarthritis, and more commonly when we deal with a gouty arthritis. The first site of pain starts from the first metatarsophalangeal joint. That is in gouty arthritis. There, you need to inject steroid into the first MTP joint, and other conditions are like sesamoiditis and plantar plate injuries, chronic plantar plate injuries. You have a chronic pain around the first metatarsophalangeal joint. So here, it's a very superficial joint. There should not be any problem for injecting into the joint. To move the joint, flexion and go for flexion and extension. Try to feel the movements at the metatarsophalangeal joint here. If not, then try to give a little bit traction and go for flexion and extension. You can feel the joint space. You palpate the metatarsal head, go distally, you will get a recess anterolateral. It is not covered by any muscle. So anteromedially, you'll feel the joint recess there, and feel the extensor hallucis longus tendon. Your entry point will be medial to the extensor hallucis longus tendon. Insert a 25 gauge needle into the joint, medial to the extensor hallucis longus tendon with an angle of 15 to 30 degree distally. Distally. Why distally? Because the proximally the convexity surface and distally the concave surface. So you'll get more space distally. So your needle should be injected distally and laterally. So this is very simple. If you find difficulty in negotiating the needle, just put with little bit traction to the distal phalanx. You will get some space to insulinate the needle. It is only problematic when there is this osteoarthritic changes with osteophytes on the anterolateral margin. Where you will have to go a little bit more closer to the extensor hallucis longus. Next is talonavicular joint. This is joint which is a complex of the subtalar joint. It has communication with the subtalar joint. It has communication with the calcaneocuboid joints, because this subtalar joint, talonavicular joint, and calcaneocuboid joint, they work together as a talocalcaneonavicular joint complex. So you get talonavicular arthritis in case of long-standing tarsal coalition, long-standing planovalgoid foot or a flat foot in elderly adolescent age group. They present with a talonavicular arthritis with a weak over the talar head. That's a telltale sign of underlying tarsal coalition or rigid flat foot. And other conditions having developing talonavicular arthritis are the isolated joint fusion. If you have, for some reason, you have fused the subtalar joint, only subtalar joint, or only calcaneal cuboid joint, they are likely to develop arthritis of the talonavicular joint. Because all these three joints, they work together as a complex joint. If you block one joint, there will be excess mobility or the other joint developing osteoarthritis changes. So these are the situations where you need to inject corticosteroid into the talonavicular joint. As you know it here, the navicular is a boat-shaped bone. It is concave distally, convex proximally. So here you have to palpate for clinical landmarking or surface landmarking. You have to palpate the tibialis posterior muscle. Try to go for supination and pronation. You go on palpating the navicular tuberosity and go superficially, anteriorly, and towards the hind foot. You will get a space just above the navicular tuberosity. Okay, just proximal to the prominence of the navicular tuberosity, identify the talonavicular joint space. Insert a 25 gauge needle into the joint from the osteomedial to plantar lateral, aiming distally with 45-degree angle. The reason behind it is that the space is more available on the distal part. So your needle should be directed distally and plantarwards. Okay, this is the most superficial joint, not a big thing to inject into it. You just remember the landmarks of the navicular tuberosity, insertion the tibialis posterior tendon. You try to use tibialis posterior resistant movements. You will find the tendon will be more prominent. You go more anteriorly, try to move the joints to forefoot adduction and abduction, supination and pronation. You will get a clear movement at the talonavicular joint, and you can find out the space of your entry of injection. This is talonavicular joint. And the last joint is the calcaneal cuboid joint. This is saddle-shaped articular space in both coronal and sagittal plane. And this is the needle is inserted distal to proximal angulation. It is because necessary for optimal placement of injection in this joint. And identification of joint line can be facilitated by supination and pronation. Same way, you hold the ankle joint, stabilize your left hand with the right hand. Try to go for supination and pronation. You palpate the calcaneum from the lateral malleus below, place it proximally and anteriorly. You will get a sudden loss of space, a gap or like a sinus thing area or that area. That will be more prominent. You will get a relative movement while doing a passive supination and pronation of the forefoot. You can identify the joint line and you can inject with a 25 gauge needle inserted to the joint from distal to plantar with a 5 to 10 degree distal to proximal angulation. So this the way you can inject into the subtalar joint also. The subtalar arthritis is also part of the this ankle complex, subtalar complex. If one joint, if you have fused the talonavicular joint earlier or subtalar joint, there is likely to develop arthritis at the calcaneal cuboid joint. So in that situation, you need to inject into the joint. So this is all about the injection into the most of the joints of the lower limb. I think the upper limb is again another session. I don't think I should continue on this. Is already one more. So to stop it here, if possible, we'll go with one more webinar with injection to the joints of the upper limb. Thank you, everybody. Hello. Am I audible?
Yes, sir.
So you can take over the chat. You can ask from the any questions in the chat box. So this in the meantime, you check the chat box. What are the questions in the chat box? And in the meantime, I would like to tell that this injection procedure, every resident must know by using this surface landmark. because you may not get an opportunity or that much of time to go to OT and prepare the OT setup for injection. Everything must be mastered in this injection to joint using surface landmark so that you can quickly dispose your patient in the OT setup. Is there any question in the chat box?
Sir, so far there are no questions, sir. So one question is there from Dr. Santosh. He is asking whether you will recommend test dose for a local anesthetic before injecting inside the articular joints.
Yes, when there is diagnostic confusion is there, you can go for an injection into the joint, especially when you have a confusion whether the pain is coming from the joint or extra-articular origin. There is always a scope of diagnostic, injecting the local anesthesia into the joint and confirm it. Once you are confirmed, then you can go for intra-articular injection using this corticosteroid along with anesthetic drugs.
Hello, sir. There is one more question by Dr. Shrikant. He is asking for Morton's neuroma, what is recommended technique?
Sir, Morton's neuroma, the today's discussion was about the intra-articular injection. Morton's neuroma is a interdigital neuroma. It is beyond the scope of this discussion. However, yes, can be injected. It is a painful injection between the painful growth or neuroma in the interdigital space by thickening of the interdigital nerves. You can inject over the painful site with steroid or local anesthesia.
So then there is one more question from Dr. Santosh. He is asking, how do you manage post-injection flares?
Post-injection flares are complications of the steroid. So you have to have just give some analgesic or anti-inflammatory drugs. Since the effect of the steroid or the anesthesia are for a limited period, it will go away. We have to see that it is not because of infection, because of your injection, or it is from the complication from the steroid. So nothing to be worried. Steroids are very safe drug. If there is some complication or the flare up, it will go away. Just take care of the inflammation, put some ice massage, put some anti-inflammatory drugs, it will go away.
So there is one more question from Dr. Arup Pratan Ghosh. He is asking intra-articular knee injection through ligamentum patellae. What is your opinion, sir, regarding this?
Yes, ligamentum patellae approach is there also for arthroscopic when we need one more portal for removal of the degenerated meniscus or a tear meniscus. We approach through the ligamentum patellae. So, but this is a place we will other easy processes are available, easy routes are available, easy portals are available. Why to go for the ligamentum patellae? But if you want, you can, no problem.
So
very capacious joint. Knee joint is very capacious joint. You can approach the ligamentum patellae. No, not an issue.
So there is one more question from Dr. Saurabh. He is asking, in case of ACL injury or cartilage injury, can we use PRP?
Again, this is the beyond scope of the discussion. Yes, PRP is a regenerative medicine. There are evidences are there for regeneration of the cartilage. Where as far as the ACL reconstruction, ACL regeneration is, there is still doubtful that whether the PRP has a direct relation with ACL injury regeneration. Maybe it may be helpful in grade 1 or grade 2 injury, but certainly not helpful in case of complete or grade 3 injury.
So there is follow-up question from Dr. Santosh. He is asking ideal interval that should be there between the two injection doses.
Ideal depends upon the condition you are using. The minimum interval is 1 week. The maximum interval has no limit.
So there is a question from Lakshmi Mohan. She is asking, after tapping a new knee infection, is it advisable to go for PRP injection or steroid should be given in that case?
Can you repeat the question once again?
As in, if there is a knee effusion after taping or after the aspiration, should we go for PRP injection or should we go for steroid injections?
It depends upon choice. What the condition it is. If suppose you are dealing with a stage 4 osteoarthritis, there is PRP has no role. So in that situation, if you are aspirating, keep the needle in place. Aspirate the joint, keep the needle in place. Prepare your steroid in another syringe, and with the same needle which is already introduced into the joint, you can inject the steroid through the same needle. But in case of stage grade 2 or grade 1 arthritis, then choice is yours.
So there is question from Dr. Abhishek. He's asking, how do you manage injection if it is given accidentally in a tendon?
If the injection is given accident into the tendon, first of all, if you are injecting the tendon, it will give a tremendous resistance to inject the volume into the tendon. So you may not able to inject whole amount into the tendon itself. If you are injecting the peritendon area, yes, you can inject the whole amount to the peritendon space, but you cannot inject into the tendon the whole amount. And that will also cause severe pain. There are evidences are there that causes rupture or degeneration, enhances rupture rate of tendons, but I am not sure that how much of injection, how many time injection leads to rupture of the tendon. But the person who is injecting the tendon, maybe he is doing in a wrong, he has not adapted the right portal, and he is not aware that when the needle is out of place of his joint. If he is sure, he'll definitely pick up the point from the beginning that the needle is not inside the joint, it is inside the tendon.
So there is one more question from Dr. Nazmul. He is asking if in the case of ankle injection in a medial approach, what should be the exact angulation of the syringe, sir?
The exact angulation of ankle should be plantar flex. And the reason behind it that if you go for a close back position, like ankle joint, the dorsiflexion is the most close back position. That means in dorsiflexion, the maximum width of the talus is engaged to the ankle motus. Hardly you have any space in the ankle joint. So whenever you go for ankle joint injection, try to go for a little bit plantar flexion. So that means the still some narrowest portion is engaging into the joint, and you can inject. You will get enough space for injection. So best position is in a plantar flex position.
So there is a question from Dr. Rehan. He's asking, in absence of any knee effusion, how do we confirm the needle placement in case of suprapatellar approach? For
I have already shown there are other signs are there also. If joint fluids are not there, you'll get the moisture in the joint. You'll have easy passage of the fluid into the joint. So and these are the things. Knee joint, if you're talking knee joint, almost all you'll get one drop part. Normal synovial fluid knee joint is more than 10 ml, more than 5 ml. So you will get some amount of fluid. One drop even you can aspirate. Okay. So if not, if still you are not sure the fluid is not coming, then you have to sure that there are the moisture in the joint, the needle is when inserting needle is passing easily, and your blocks in initial place, when you start injecting, it is going smoothly into the joint. Patient do not complain of any pain just after injection. So these are the signs where you can confirm that it is inside the joint. However, I will suggest if there is no effusion, please don't prefer this suprapatellar pouch area. The best way is to go for the mid-lateral approach for the knee joint, where the knee joint is almost superficial. Just the retinaculum is there, lateral retinaculum is there between your joint and the needle. So it's very easy. Go through the mid-patellar or even supralateral, even just at the upper pole of the patella. Okay, so if you're not just still, you direct your needle up or down, you will hit to a bone. Then hitting to a bone also confirm that you are inside the joint.
So there is question from Dr. Nema, where she is asking, when there is no knee effusion, what is the preferred approach of injections?
Best approach, as I said, it is a mid-patellar approach, lateral mid-patellar approach, the best way. It is the joint is almost superficial. It's just enter, it will be inside the joint.
Yes, sir. Sir, Divakar sir is asking, how do you manage if the steroid injection is given in early septic arthritis?
No, first of all, it is a contraindication for giving injection to septic arthritis. If by mistake you have injected into the joint, nothing to worry. You have treated the same as the protocol of septic arthritis. Joint lavage, culture sensitivity, antibiotic injection. These are the protocols. Nothing to worry. You have to treat as when you get to know that this is septic arthritis by mistake you have injected. Nothing to worry. You treat the condition as septic arthritis.
That's it, sir. No more questions in the chat box.
Okay. Thank you all for joining this webinar. So at the end of our webinar, I must thank all the participants who have joined this webinar. I hope everybody must have gone back with information regarding how to exactly approach the different joints of lower limb. And I must thank all the office bearers of APMRO and office bearers of IAPMR for constantly supporting us, organizing this webinar. And before ending, I must thank all my staffs of PMR department of SVNIRTAR, all PG students, all faculties of SVNIRTAR for constantly supporting and encouraging me for organizing this webinar. I hope in future also we'll organize more and more webinars with clinical talks, which will be helpful for the residents. Thank you very much. Good night.